Hi, my name is Malik Kaman. I'm an associate principal with ZS Associates, and I'm here live today at ASCO 2018 with Dr. Lee Schwartzberg. Dr. Schwartzberg is the executive director of West Cancer Clinic and also professor of medicine and chair of the Hematology Oncology department at the University of Tennessee. So what do you think are some of the drawbacks to using these novel endpoints? Is it just obvious that we should be using them all the time?
So in some ways our science is a little ahead of the clinical explanation of it, because it's getting easier and easier to find very rare cancer events. I'm involved in a lot of trials with cell-free DNA, circulating tumor DNA.
That was one of the ones I wanted to ask you about.
Yeah, it's fascinating technology. It has lots of particular uses, but the one we're talking about right now is, can we monitor for minimal residual disease, and particularly as it relates to breast cancer, where I've been working on, is after primary therapy, if you still have circulating DNA, what is that telling you about what will happen with a cohort of patients? Is it simply a lag time phenomenon, and you're going to see that patient relapse, or can you intervene at the time you're still seeing that and perhaps prolong disease-free survival, or perhaps even cure more patients?
So it potentially becomes a prognostic biomarker for who's going to do well versus not well after the initial intervention?
You raise a great point. So these biomarkers could be strictly prognostic, they could be predictive, strictly predictive, or I think many of them will be both prognostic and predictive, and separating out the relative values of both of those is important. I think the biomarker that has been best established as a surrogate marker recently has been pathologic complete response in breast cancer. We now have very well validated meta-analysis that shows if you get a PCR to a brief course of chemotherapy, or whatever the therapy is, you're going to have a better event-free survival and long-term. So that accelerates drug discovery, because instead of waiting, in the case of breast cancer, for many years, since the event rates have gotten, thankfully, very low, and waiting for 10 years to see the outcome, you can predict that outcome based on PCR, and actually FDA has accepted that as a conditional regulatory endpoint to approve a drug.
Are there any endpoints that you feel like are critical that we start incorporating into clinical trials routinely today so that we can have better information in the future?
Yes, I think the area that has lagged behind is patient-reported outcomes. There's been a lot of work and good work that has been done by NCI and FDA and people that are interested in PROs to create a common toxicity for patient-reported outcomes, and those are just now starting to get integrated into clinical trials. I've been involved in collecting patient-reported outcomes electronically for about 15 years, so it's something that's near and dear to my heart. And I think we're also at the point now that we've seen that you can actually have tangible benefit, even to the point of overall survival, as we heard in the plenary session at ASCO before, that we can see that if you measure patient symptoms, and that gives you a better opportunity to act on them routinely, and you can do it now electronically very conveniently, you can get better outcomes.
It's really exciting. Well, it's been my pleasure to chat with you today. Thank you very much for giving us some of your time.
Absolutely, my pleasure too. Thank you so much.